And finally, there's the issue of, can a screening test like this actually pick up not just dementia, which of course is highly desirable, but as Sita has said is an end stage problem, is do we have any reliable test to pick up early dementia? Let's not call it MCI, but early stages where you think you can intervene. And I think there is emerging evidence that scales like the AD8 can pick up CDR 0.5 at least, or MCI, but a lot more, it needs to be validated in other countries as well. So in summary, I think that if we're going to recommend anything, please make it simple. Please validate it in your own country. Do not accept other people's cutoff points.
Yeah.
Silence.
Can something like column drawing be used as a substitute for block drawing test?
I'm sure many people. Swarna Aladi is one person who constantly talks about it. But the problem is, how do you test men then? Because women are the only people who draw column, especially in rural areas. But if you're going to have a tool, then it has to be exclusively rural, because I'm sure I do not know how to draw a column, despite being a South Indian woman.
I don't think you want it to be an overlearned ability. I don't think you want them to draw something with, right?
Ma'am, if the essential criteria for dementia, is loss of previously learned abilities. So a South Indian lady who has been drawing columns all her life, not being able to draw columns is definitely not a normal thing for her.
That is correct, but then it's not testing the same thing as clock. If you're testing
it's different, I think.
Clock, you're trying to get either visual, spatial, or executive function. You're not going to get that from an overlearned behavior. Certainly, you can use it as a memory test, a unique memory test.
And even in early, it may not be an early feature also. That's another problem. Apart from you are testing something different, I think that we have to take this decision that paper and pencil test, where you have to sort of perform in public in front of another person who is testing you, is probably not a good idea to test older people in Asian countries who are predominantly illiterate or had not had formal education and had never been asked to do tasks like this. Give a paper and pencil and then draw. So I think, and this is proven to be not fair. It's not education fair test. So even clock drawing test is not an education fair test, because people are very anxious or not used to perform well in public domain. There is problem, education bias is there. So that is not a good test. So anything which would not require a paper and pencil test, which is much more, which wouldn't require any other equipment, that is easier. Yeah. Those are possible alternatives to test this.
I don't know. I mean, the MOCA with some adaptations, perhaps to some extent fits the bill in many ways for cognitive tests. And I don't think we should be reinventing the wheel, but I think if we say list of tests that can be adapted in the Asian environment depending on the convenience of the, so if we're putting a list, then I would say that we should think about which are the tests we would put in that list. Tests, of... Yes. And then we would also obviously put into that list something that tests activities of daily living and functional ability. And we would put into that list something that tests disability, as was pointed out yesterday, in a wider way. So in a sense, recommending a pool of instruments that could preferentially be used may be one approach that one could take, because as Mary was pointing out, you don't want to sort of say, oh, only use this, because then there are many people who are not comfortable using it or don't have access to it. So Well, I think comparison is for research. So in a sense, if you are starting a project, then obviously you will have to get everyone who's participating in it to use the same instruments. But in terms of running services and helping people with dementia at different levels, I think we can't be so exclusive as to say only this can be done. We have to give people some options which we think will work for very specific reasons.
I find that in the discussion that we have got certain objective, cognitive, tools which are, the idea by Chris is that, use something simple and validate it and in your own population. And I think that's what Mary has been saying. We have got ideas of CSID and MOCA. What else? And Chris also talked about the informant. So far, AD8. Yes. I just finished and then you can come in. I just want to check about what ESK said about functionality, because one is we have the EASI, that is EASI by the Balabag group, and then yesterday we have been talking about the Bartels one. So I would like to hear people talk about that, and disability, of course. Well, I think you talked about DAD. Linda did, I think. So I think some things on people's, experience and also on what suits them. We can have some discussion on those. Chris, all yours.
Oh, no, sorry. Just to say that Mary has asked me to go and comment on the feasibility of developing new tests and not just using old tests. And I think that at least in Singapore, we know that our population is becoming more and more computer savvy, and we are shifting more and more from face-to-face interviews to using programs. And the initial problem was that many of the assessment programs were really not very user-friendly for the elderly. But that seems to be getting better now with touchscreens and also with programs which are a little bit more like games and not so threatening. So we have used computer-based assessment for clinical trials, and they seem to work well in the clinical trial population. I think that we should really consider whether there are any sort of new developments that we can use for other communities. I mean, I don't, look, if every Indian, Filipino, Chinese person I've seen can text on their phone and aspire to having an iPhone, I really don't see why they can't do computerized tests.
What is the age group you are doing this for? 50
60 to 70. I mean, these are people who initially refused to do computer-based tests based on keyboards and things like that, but they all have iPhones. And they're all playing with the little kitty cats and the Angry Birds.
Angry Birds.
I don't believe that we cannot fashion better tests.
I think a very valid point.
Angry Bird test
Angry psychiatrist.
I am Dr. Ramanujam from TIMS VHS. Nobody touched upon cortical dementia and subcortical dementia and the classification. And if anybody can throw a light, it will be very useful. And secondly, I have seen that some of the people respond very well to rivastigmine transdermal patch rather than giving oral tablets, because most of the patients are above 60 and their absorption will be very less, and transdermal patch is quite rewarding. Thank you.
Would like to respond, but I think one of the reasons being that we are mainly focusing on the diagnosis and the tools to be used on. So cutting across all types of dementia, and that's the reason why people have not gone into, specifically, I don't think except vascular dementia we have spoken about anything else, including, not vascular, Alzheimer's dementia. We have not spoken about specifically vascular dementia, cortical and subcortical dementia. And of course, the other question is, I think, for the neurologists, I think, again, into intervention.
Suggestion, that's all.
More to do with the intervention. I still would like to come back to people talking about disability and functionality.
Can I also ask a question? can answer this. In terms of, if you're measuring something with the DAD, does that also include functionality? Do you need to have another scale for functionality, or will that cover pretty much most of what you want to know?
For the DAD, it actually assesses both instrumental and basic activities of daily living. The items included the things that we mentioned yesterday, from self-grooming, self-care, hygiene, to more community living requirements like finance, meal preparation, medication management. So the beauty of it is you can have an the assessor needs training, but it does not need to be a fully trained professional occupational therapist. And the items itself is what I mentioned. It should be gender and cultural fair. You can have a bit of adaptations. Our Chinese DAD have a bit of adaptations in terms of writing checkbooks, and we scrap this item because it's quite uncommon for the elders to write checkbooks in this cohort. So we change a little bit. But because of the not applicable items, so a lot of discussion about elders who never cooks and who never writes, and you can just take it away, and it does not affect the total score. So and also the DAD has been validated is sensitive in the earliest stage of dementia across the board. It does not mean that it has to be Alzheimer's disease. Other dementia is also sensitive. The sensitivity range is quite good. But if we want to check the transition of normal to MCI, that might be a problem. But from MCI to early dementia, that should be quite okay. At least in our experience, it's good. It's easy to be done, and the sensitivity range is acceptable. We can adapt some of the items to make it locally valid, and it is semi-structured, and you do not need a total translation into different languages. So it fits the needs of most, from my own experience.
And how long does it take to complete?
If you have a knowledgeable informant, I think 20 minutes will do. Yeah, but if not, then if you need the assessor to assess, of course, then it takes a much longer time.
And at what level would you recommend it to? Secondary care,
primary, we use it in research as well. We use it in our research as one of the to assess the community subjects. So our research assistants will do it, and we use it as an outcome indicator for the non-pharmacological intervention, and we use it in the memory clinics.
20 minutes, he said.
20 minutes for a reliable informant.
Do you need training?
Yes.
You need training,
but not the very sophisticated training, because he just asks if he or she is able to prepare light meals as usual, if he or she is able to take a bath, if he or she is able to manage.
Is there a manual attached to that?
Yes, I think it is easily available, and the original offer is very. It's free. It's very friendly, and she allow us to use to make translation very readily. I think it's with the Gauthiers group.
Yeah, that's what she said. In
Yes,
the
it's
community, it's
Gauthiers
the
group.
health workers who do that. I just wanted other people in the audience, people who are, to AD8.
Thank you. I would like to talk a little bit about AD8. Actually, AD8 was extracted from clinical dementia rating scale from CDR. It seems that it extracted the course questions about how we can evaluate a person, an individual with cognitive impairment, especially for dementia. So totally there are 8 questions, and these 8 questions included about the evaluation about judgment, orientation, memory, and also their financial skills, complicated social activities. But within this 8 core items, actually, we can change the example. We can like make culture adaptation for examples, but examples are not quite specified. You know, in the United States, the original version was in English. They use like some of the functions like paying bills and like preparing the gifts for holidays for friends as the examples that whether the individual have the judgment difficulties, they have difficulties to manage sophisticated social function. But I would think that the core symptoms are quite good, but the examples definitely can be adapted to different cultures. So in our experience, when we are using the AD8, it's easier, and when we give this to the key informants after we give public lecture in the community, most of the elderly, they can answer the question by themselves. They can understand the question easily, since actually the instruction was quite simple. Just ask about whether the older person you are caring or at your home have some changes over the years due to memory problems or thinking problems. So it's easier for them to identify, and they only need to put question mark that whether there is change or whether there isn't any change. And then if that's questionable, they don't know how they can assess, they can also put the mark that I don't know how to evaluate the problem. But for this, for the AD8, we think after our validation test, we found that it is highly sensitive to identify the some of the changes of the elderly individual, but there might be like too much high, like positive, like false positive. So probably we can think about whether we can suggest to use AD8 and combine it with the other simple objective cognitive performance. Maybe like CSID, there are a couple of questions asking about the subject, the elder himself, or maybe we can put like the GP cog for the elderly person himself. But we need to find out whether the combination can increase the specificity, and in that way, probably we can save much time for the patient to be referred for secondary care. But for screening, I would think that AD8 might be appropriate for the primary care.
AD8, is there a qualification where you say that this inability to do is due to physical illness or a physical problem, for example, muscle weakness or something like that? No, is there an option wherein the informant is asked, is it possible because of a physical problem, he is unable to dress or whatever, do?
Yeah, actually, the instruction has pointed that this changes should be due to the memory problems or due to the brain problems, not due to physical.
I think that way AD8 has an advantage of insisting that there has to be a documented, reported change from a previous level of activity, which that ability is not there now. And again, that is not due to a physical disability, and it is cognitive or presumed to be cognitive by the informant. I think that's good.
I think I'm just going to stop the discussion. Continue or?
We can give it. We're waiting for that to come down.
All right. Because we can take one or two more discussions, and then we adjourn for the picture and also for the lunch.
Can I just ask a quick question? Since you're using the AD8, do you feel that it's equally good as screening for dementia generally, or is it just for Alzheimer's? Because it was designed for Alzheimer's, and it's very, yeah, it's not really. I mean, everything at Washington University is very focused on Alzheimer's disease with memory, and it's validated with the CDR, which is again very. So I'm just wondering, if we keep talking about all of these scales that have been validated for AD, whether it will diminish our capacity to pick up subcortical dementias, vascular dementia, all of those other things, if you're just ignoring all of those. So I'm just asking for your experience.
Three of them, I think 3% are functional, whether they can do things. They are functional principles.
No, but I mean, think about what functions are affected in FTD versus AD. It's not essentially the same, you know, and so these are more rare, but if we focus your entire strategy on tests that have been designed to detect one particular form of dementia, are you going to compromise your ability to detect others, and does it matter?
I think executive function impairment should be picked up by some of those persons, because predominantly this is going to be vascular or AD. So if you can pick up both, then the investigating problem is very hard to.
The one other consensus point which may be worthwhile thinking about is the importance of behavior in dementia diagnosis or screening for dementia. Is there a way in which one could red flag certain behaviors as being, important when we decide to screen? Or, they are markers which tell us, behavioral markers which tell us. I think we should have our photograph because Aditya De Silva has to leave. So I'll leave everyone with this thought, and maybe lunch will also energize you to think a bit about behavior. Your eating behavior will be watched, for example.
In the light of the need to have lunch, and in the light of Dr. Azita leaving at 4 a.m. to Sri Lanka, the mementos for the panelists for this session would be distributed at the end of the next session.